Okay, we shall get started. So hello and welcome everybody, and thank you for joining us this evening for our webinar on solutions for pain and dysfunction incorporating IASTM and biomechanical taping. I'm really pleased to announce that this is in partnership with Physio Supplies, who we've recently started to collaborate with. Alex Nesbitt and the team at Physio Supplies offer a fantastic service and with their cost-free analysis to help you save money on your consumable spend. So thanks to those guys for helping support this webinar this evening. I'll be sharing some more details about Physio Supplies towards the end of the session. With this webinar is going to be in two sections. So we're joined by Keith Cronin from Colorado, USA. So another international speaker for you that we're bringing to the UK shores. He's going to do a 20 to 30 minute presentation and a demonstration of how to use IASTM and dynamic tape. And then that will be followed by a question and answer section where you can ask him some of your questions from what he's presented. A little bit of housekeeping. If you do have any questions at any point during the presentation and demonstration, there is a question and answer tab at the bottom of your screen. If you select question, type in your question, and we will get it answered at some point. And also just to remind you that this session is being recorded. So if you do miss anything, we'll send out the recording following this session so you can catch up on anything that you might have missed. Just for those who don't know who I am, my name is Dominic Smith. I'm the clinical application specialist at PhysiQuip. Anybody who doesn't know PhysiQuip, we are a medtech distribution company, and our aim is to bring some of the latest innovative technologies from around the world to the UK, and also as well as technologies, speakers, hence why Keith is joining us this evening. With all that being said, I'm going to hand over to Keith and he can deliver his presentation. Keith.
Fantastic. Thanks so much, Dom. Well, welcome everyone. My name is Keith Cronin. I'm a physiotherapist here in the United States, and they were kind enough to invite me out on this because I've come out before to teach this information. So we're going to try to do this via Zoom today. So the great part about this is I'm just going to give you a very short amount of information about each. This is sort of like a teaser so that you get a little bit of background on how all these things work together. And at the end of it, if you have questions, you're just going to shoot them my way and I'll be happy to answer them. So again, this is more of a synopsis of everything as opposed to going very in depth, but I'll be happy to answer any questions as we go along. So with that being said, here we get going. So what the idea of this is using mechanical solutions for pain control. And to actually improve function, the dysfunctions, the function limitations that you see in the clinic, what we want to do is try to find a way to mechanically address it, because as physiotherapists, that's what we do. We manually, mechanically, and functionally change the way that people move. So this is sort of an overview of this sort of systematic approach that I've used over the course of the years. By having an approach, it means that you have an aim, a purpose, something that you have a guideline on. And by doing so, what it allows you to do is have focus in what you're doing. So with this is a mechanical approach of using instrument-assisted, dynamic stretching, then using a biomechanical tape, which is like a bungee cord, and then followed by that with something that's called a VibraCool, which is a high-frequency vibration, which is a mechanical way of addressing pain. So why do we have this sort of three-tiered approach? Well, you could say all these things are just products and like we're here just to show you all products you can use. Well, it's not just that. These are extensions of our learning as well as our mechanical hands. So we can use these things in conjunction with these and put together a solution that would improve the overall function of an individual. And this can be used for a variety of soft tissue issues. Now, the big question I've had people ask is, why these three things? Why do I get so passionate and interested in these? Well, it's because of the following. Whenever you have someone with any chronic issue or even an acute, you're going to have some sort of fascial adhesions. You're going to have limits with range of motion, difficulty with blood flow. And then they're also going to have issues with the workload that goes to the body. They're going to have difficulty moving correctly. They're also going to have a lot of pain. And they're also not going to be willing to really want to get up and get moving because, quite frankly, it hurts. So with that, when you take these three things, it allows you to do treatment in the clinic, but then also take your treatment outside of it. So to start with, why instrument assisted? Well, hands can only go so far. And it's because we can use these hands to do your mobilizations or manipulations, your soft tissue work. But by using the beveled edge of an instrument, it allows us to get deeper into an area and to be more focused with our treatments. So where did all this instrument assisted come from? Well, it actually came from gua sha, which is going to be, again, loosely translated as bringing blood flow to the surface. But you'd use a whole bunch of different things, you know, from buffalo horns to rocks and stones and anything that you'd find an edge on. Well, this is a far more aggressive version. We don't generally teach this with the instrument assisted courses that we do, but the idea is do something to the body mechanically and then have an effect. By putting a treatment tool at 30 to 60 degree angle, ideally, what it allows us to do is get deeper into the tissues to break up those fascial adhesions. And then we're having a mechanico-transduction effect of putting pressure on the body to make something happen. Now, why these things work? Well, there's a few reasons why they work. The first of which is that neurophysiologic effect. If I put pressure on something, I can change the way a nerve fires from its location afferently up to the brain, and efferently change the way that you react to things. That mechanotransduction, I'm putting pressure into the body. When you break in crosslinks, when we have individuals who have chronic injuries, they're not here because they're doing well. They're here because everything is broken and everything is laying in the wrong directions. And also from things like fluid dynamics. We know if we do anything with our hands, we can cause lymphatic drainage. Well, you can do the same thing using these tools. Now, we've had a lot of people ask, like, well, what side of the tool do you use and why do you use these tools to start with? Well, you want to use that beveled edge of it because it's going to allow you to have sensitivity and specificity within that tissue. With a hollowed out steel like you have with these particular ones, like for hawk grips, you can actually feel every time there's an abnormality within the tissue. And that is really, really important because you, as clinicians, are your own targeted, very specialized individuals who have a great sense of things. These things only heighten your senses and being able to focus on the areas where you want to. Sometimes you use it on the other end because you can use it for things like desensitization. You use that softer treatment edge. I've used this a lot with kids with chronic regional pain syndrome to try to normalize nerve endings. And this is a different approach than using your hands because, again, your hands can only go so far. Now, when we use the tools, it gets us into a point where we go, okay, so what are we going to do with these things? We've done the tool part, great. Well, now we need to do managing motion, right? So when we talk about why this segues into biomechanical tape is because when we started, we've done things with our hands and our tools to be able to break stuff up. We've gone through our treatment options. We've done our dynamic stretching. We've done all those types of things. The problem now is we have weakened tissue that is not working appropriately, and this takes time, and we know that as clinicians. So what does a biomechanical approach to taping do? Well, it takes the load out of the body. So when we have a biomechanical approach, we're probably familiar with that with rigid taping, right? You put it on the body, it stops it from moving. Well, that's great, but it doesn't allow you to move, and we need movement to be able to heal. So knowing that, using this biomechanical approach, which is step 2 in this phase here, it allows us to have get the neurophysiologic effects, which is just putting tape on somebody, which you're going to have, but then also being able to change the way that people move. Now, if you're not familiar with this particular tape, it's not like kinesiology tape, okay? And it has a bit more function to it. So it allows you to handle some of the limitations that you've had before. Like if you use rigid tape, you can't move the joint. If you put kinesiology tape on the body, it's not going to absorb force. It's just going to lift the skin a little bit. And you also get tape fatigue, which we're all familiar with, where, you know, you put it on an ankle and then all of a sudden it starts stretching out and the joint starts moving. Well, this is an approach from a mechanical standpoint to be able to address all of those issues and do it in a very efficient manner. And the reason you can do that is because it's not made of the same stuff. So if you look at dynamic tape, it's made of nylon and lycra. Think of it like going to Lululemon and it's like really, really, really nice tape you stick on your body. Well, this is the Lululemon of tape. Okay. So this is the stretchy pants that makes you able to move the way that you want to, and it stretches in all directions. That's important because if you're going to have a mechanical effect, the topic of this conversation, you have to be able to mechanically change the way that the body moves. And you can't necessarily always do that with other tapes. And that's why for this particular approach, if you're going to tape in this manner, where you're going to have 3 things that you're going to do: cross a joint, apply it in a shortened position, and get good purchase on each side of the body part. What that's going to do is allow you to control motion. Because remember, we broke up the tissue, step 1. Step 2, we're going to now control the way that it moves. And by doing so, it's going to allow us to control the force that goes through the body. And that's what we do as clinicians. And probably the most important thing that we do is that we're able to control load through the human body. And it's very, very critical that we are able to do those types of things. So knowing all of that, we have our approach. And again, this is just a short and condensed version. First, we've used our tools. We've broken everything up. We've done our dynamic stretching. We've gotten the nerves gliding all over the place. Great. Next step, we have now gone, when they're leaving, we can take the load out of the body using something like dynamic tape, which again is a biomechanical tape, with the thought process of the following. We have a purpose. We have an axis of rotation, we have a line of pull, we have a position, we have a leverage, and then we reevaluate. This is a very mechanical approach to being able to do rehabilitation. And when you put all of these together, it allows for that nice combination of things. And once that's established and you have better movement patterns and you've broken up all the soft tissue issues, there's one thing that we also know that they're going to have an issue with, and that's pain. And no matter what you say, do, or think of for your patients, if you don't do something to address their pain, you're never going to get to the next step. And so it took years of trying different solutions out there. And then finally, I found the mechanical one that was very successful, that matched well with using the tools, with using the tape to control motion, to take the load off. Because as you know, there are tons of things you can do for pain. But we also know there aren't a ton of things that people will necessarily, this is going to work instantly. Well, we have to give people some sort of instant relief of pain. So traditionally, we've gone to things like TENS units, right? So you put that on there, it gives you the electrical stimulation, but the challenge is it doesn't hit all of the right stuff. So going back to our previous one where we were talking about our mechanical transduction, right? We put pressure into the skin, and we know when we use those tools, we can have an effect on pain. We know when we stick tape on skin by lifting up, it can have an effect on pain. Well, the trouble though is if you use tools and then you use tape, you can't even have your TENS unit attached to it because it can't go through the tape. And then your tape has trouble sticking on there. And so you're like, well, what do I do? Someone have to send home to do something to address all of this stuff? Try to go explain the frequency of hertz to a patient and saying, this is the particular hertz that's going to control this particular type of pain. Well, that's not fun. But what we know, though, is that if we work with the science of things, we can address all of these issues right here. Because when you use a TENS unit, it's creating an electrical stimulation which causes a muscle twitch. And what you'll see is if it traditionally is going to hit some of these ones in here and in here, but the Pacinian corpuscle is responsible for about 90% of your pain control. But here's the problem. We don't hit it with our current means of being able to address pain. When you use your tools and stuff, you're pressing down on it. So which means you are going to be hitting these mechanical receptors. But the challenge is when you go home, you aren't there with them. So in which case, if you have something that you can send home with them, that is a high frequency vibration that we'll show today in the demo, that can go on top of your tape, that can still be used with your tools. Now you have a 1, 2, 3 approach. You can break up the soft tissue, you can control movement, and you can send them home with something that is pain control, but is not contraindicated, and it will work with the tape and with the tools. You put all of those things together, and now you have a very strong mechanical approach to managing pain, dysfunction, motor patterns, and all the types of things that you see on a daily basis, whether it's acute, chronic, all of it can be addressed just by putting these three things together. And they're not done in isolation. I can't highlight that enough. The whole idea with this is that they're used as part of a complete treatment system that does not replace anything. If you don't know what you're doing, this won't work either. So with that, my goal after this, I'm going to be showing you, and I'll be flipping my camera around to show you how I'm going to put all these things together in the best way I can possible. Please note, I'm doing this at my house, in my basement. I've got a whole bunch of equipment and stuff, but I'm also limited by the fact that you're going to have to see my foot, which I'll be treating today at a very close-up position. So you're just going to have to deal with it. Okay. Now, with that, this is, if there's any time, Don, if you have any questions you want to ask right now, but otherwise I'll just zoom right into getting this set up so we can show this stuff live.
So yeah, no, that's perfect. Sorry, I got stuck on mute then. Yeah, so if anybody has any questions on that presentation for now, while you're just getting set up, Keith, please just submit them into the questions question and answer. Hopefully, obviously, the demo might actually give people a little bit more insight into how you can actually apply the tools, the tape, and the VibraCool as well. I suppose I think just more from my point of view, I think there's a lot of people that will know. I think it was nice actually how you broke down kinesio taping, you know, your rigid taping, dynamic taping, that kind of thing. I'm sure you're going to show us, but if you, what's like sort of the main differences when you apply the different types of tape?
Absolutely. So you heard I'll be a little bit more of an echo, and you all still able to hear me?
Yeah, still good.
Awesome.
Yeah.
So you're a little bit more of an echo because I'm just in a different room, and while I'm setting everything up here. So with a biomechanical tape, you place it in a shortened position, and again, it's like a bungee cord. If you're using something like kinesiology tape, it has about grams worth of strength. This has kilograms of recoil. So if you put it in a shortened position, think of like what you do with a bungee cord. It's going to, as someone moves, it's going to absorb the load like a squat. They're going to squat down. It's going to absorb the load out of the knee joint and around the knee joint. And then when you pop back up, it's going to take that potential energy and it's going to spring it into your movement. And why that's really important is because if someone is having chronic issues with pain, the reason they're having, it's going to stop movement. We know in the ACL, if you have just a tiny bit of fluid in there from, say, an injury, but 50 milliliters of fluid is enough to shut down your quad. Well, if that fluid is still there, you need to, while the treatment, get that stuff out, restore normal movement, and then abnormal movement patterns will create joint damage, which will create more fluid. It's a nasty cycle. Yeah. So if you can absorb the force around it, it'll allow the body part to heal. And then once you don't need the tape, you get rid of it.
So I mean, I suppose actually you mentioned pain, I think, which appeals to one of my main philosophies. The first time I see a patient, obviously you do all your assessment and that kind of thing. Is pain pretty much the first thing you address?
Yes. So I want to talk about pain. I want to figure out why they're having it. I want to figure out the psychosocial issues as well. But then I want to do something day one that is going to have an effect on their pain. And in all honesty, it's making it better or worse, because we know if you can make something worse, you can probably make it better. And to show that you can modulate, because right now they're in a belief they're always a 10 out of 10 pain 24/7. And unfortunately, pain has a huge perceptive component to it. Someone can break their leg out in the woods and then work their way back to the highway. Once the ambulance shows up, they fall over in pain. That's because it's the body's protective mechanism. But the reality is we have so many individuals who are in chronic pain, and because of COVID, it has only gotten way, way worse. We're isolated, we're depressed, and we're having unhealthy habits, and that makes pain more pronounced than it's probably ever been in the history of humankind.
Yeah. No, sure. No, it's one of the things that I first deal with is the pain. Patients come to you with pain. They're not bothered if their shoulders up, down, forward, back, or whatever. They're in pain. So it's very much sort the pain out first, then they'll come back for the rest. So
right.
Are you ready for your demo, Keith? Yeah?
You betcha.
Wonderful. Whenever you're ready, you can flick your camera back on, and then you can get into showing the folks how to apply the tools, and hopefully that will spark some more questions. Just as a reminder for people, if you do have any questions, then there's a question and answer tab at the bottom of your screen. If you're on your phone, I think you have to click onto more. It should be, if you touch the screen, you can click question and answer, and we shall get them answered for you. Otherwise, Keith,
all right. So what I'm first going to do is just kind of show you what it all kind of looks like together. Okay. So inevitably, there's all your different stuff. So in that much space, you're able to have everything that you need to be able to do what I'm about to do right now. So this isn't talking about big, giant, bulky equipment that takes up a ton of space. So we have all of our stuff here. Beautiful. Awesome. Okay. Now I'm going to walk you through it. Now we're going to get the camera angle right here. So remember, this is not the ideal position that we would be working with any patients. Okay. But for instance, what I'm going to be showing you is I'm going to be showing you a treatment on if I was having, say, plantar fasciitis. So even using the tools, you say, oh, well, I have plantar fasciitis and it hurts here. Okay, wonderful. But the issue is also up through the entire kinetic chain. Okay, So we can't just look at this. This could be a captured nerve right here. This could be something where they have a lot of tightness in the soleus as well as the gastroc, and it's causing impingement of nerve all the way down. It could be tight tissue here, but it also could be weak. We don't know that. So what we want to do is first start with our tools, okay? And then what we're going to be doing, normally I would normally put on an emollient, which that would be something that would go between the skin, but just for time-intensive purposes, I'm not going to do that today. So we have our beveled edge right here, all right? And so I always want that facing down through the skin. So if I were to flip this the other way and I go like that, I'm not grabbing the edge. I have to make sure that the edge is always working down. Now, if you're working with a patient, what you would probably do is have them laying on their stomach, okay? And I would work all the tissue up and around all the way through the body, even up into the hamstrings. So even though you have a foot issue, you're going to treat all the way up into the back part of the leg. And in each area you can focus on for 30 seconds, maybe 45 seconds to work all through it. But the goal is we're putting pressure in the skin, again, that 30-60 degree angle, and then coming up and in. Now you get to a part over here and you're like, well, wait a minute, Keith, I can't work on this spot here. The tool's too big. So, yeah, that's why there's multiple tools, right? And that's why we have a different set of this, because this is going to allow me to work up and around the soft tissue. So as an example, if I was having that plantar fascia pain, I could work right down into that aponeurosis that goes around the soleus and the Achilles. I could work down into the tissue, particularly that you're going to see down in the heel. And one of the best ways to do that is a really kind of a fun way where you take this tool, you press it in there, and you actually twist and turn it like this. And some people go, why the heck would you do that? Why would you spend so much time working through all of this tissue and using this really specific instrument? It's like, well, I can feel right there every single time I go over a little railroad track. I can feel that with this. If I'm going over and I don't have something that's as specific as this particular tool, I can't feel that. And by the way, when you get your fingers out, you can't feel that either. So you could have been doing manual treatment through the whole thing. And here's the reality. All of their problem was caused by a spot right here. But you wouldn't know that unless you could evaluate the entire area. So each time they come in, you're working everything. But the whole thing was, if you had just gotten some focal treatment right along the inside of the part there, say, where oftentimes people get nerve entrapment, and all of a sudden the nerve pain goes away, which means the muscles reactivate, which means the flexor hallucis longus works nice and well, which lifts up the arch, and then we don't have a problem. To do that, you kind of need something like this to be able to work into that tissue. And the whole time I'm doing this, my hands aren't getting exhausted. I can only do this for so long, everybody. Once you do it enough years, these things do wear out. Here's the good news. This thing does not. So we've gone through and we've worked all of our tissue in different positions, in the shortened position, in the stretch position, right? We've done all of that. And now everything's nice and loosey-goosey. We've gone through and then we've done our nerve stretches. So this is where you take them through and doing dynamic stretching. It's just a little tough to do it on a camera right now. And everything's loose, cool. All right, you're in a position to do rehab. You go through your entire treatment. Awesome, wonderful, I love that. Now they're gonna leave. Well, what are you gonna do? It's like, well, you gotta send them home because now you have broken up things that are very weak and tight, and they are not going to work well. They may feel good right now, but in 24 hours, everything is going to restore mostly back to normal, and all of their weakened motor patterns are going to exist again. So we've now used these things to do a good job, but we need to have more of a solution. So I'm going to move this camera again. All right, we're going to turn it down right to here. All right, perfect. Okay, so my foot's nice and loosey-goosey. So I'm actually going to turn it this way. My foot's feeling good. Is my foot on there? Perfect. You see that lovely foot. You can send this out for posterity's sake later. You all can use this camera footage if you so wish. And if you do, I'm questioning everything you're doing in life. Okay, now, here we go. Here's this little bungee cord tape. Now, you're gonna see here, this is dynamic tape. So this acts like a bungee cord on the body. So if I take this and I'm gonna put it on a shortened position on my foot, and the cool part is, and I'll just show a quick example. If you have kinesiology tape at home, it does not do this, all right? That's because this has high recoil to it. And I'm going to use that recoil to help with my plantar fascia, because inevitably the plantar fascia is a load absorbing structure. You have 1/4 of all the bones in your body are in your foot. Well, there's a reason. It's designed to absorb force, hit the ground, and then absorb it and put it appropriately through the kinetic chain. If you have plantar fasciitis, you essentially have a block on your foot. And don't be shocked if all of a sudden from plantar fasciitis, you have knee pain, hip pain, back pain, because you're no longer absorbing it here, you're shooting it up the chain. So let's stop the problem where it exists. Okay. So to do that, I'm going to put this tape on. I'm going to put it on my toe here. Okay, and because I'm going to use the toe as the mechanism to actually get this thing moving. Now, if you've ever done kinesiology taping before, this is not kinesiology taping. So please understand this is completely different. All right. So I'm going to take this and put it in a shortened position. All right. And what I'm going to do, is I'm going to take it along the underside of the foot. So I'm going to pull it up and come along the outside. Perfect. And what this is going to do, and I'll pull it around the other, and I'll show you guys the end result. Perfect. Awesome. All right. So what I have here is, first of all, you will notice my foot looks way cooler than it did before. So if you know nothing else, put dynamic tape on your body, and it looks cooler. All right. I put it in a shortened position because what's going to happen is as my foot pulls up, the tape is acting as a recoil, and it's springing everything. So as my foot in a sitting position now, if you can see, it's kind of like curled. I have to force it to open up. So what happens is when I put my foot down and load it, I'm now loading through the tape. And the really cool part about that is now the tape is going to take 5, 6, maybe kilograms of force. It may be a little bit lower depending on how much tension you put on it. But with high speed, it recoils faster. So the more speed you put through it, the more force you actually unload, which is why this works great with high performance athletes, but it works with your daily weekend warriors as well. And this is going to now lift up my arch. So you've now sent somebody home. You remember you've worked all this. You sent them home, and now they have a solution that every time they move, this is going to be supported. But as I said before, got one more part to it, because even with this and even with these, they're still going to hurt. And there's just no way around it. So what we then do is we have a different solution for it. So I'm going to pull this up again. So this is what's called a VibraCool. Okay, it is a combination of high frequency vibration that's low amplitude. What that means is it's perfect for addressing chronic and acute pain. It's just a little thing, and it creates a little buzz. And what this is originally from was needle sticks. So they use this. Say you were getting a shot, and they did it with kids. You put it here, you put this here for about 20, 30 seconds, and then you do the needle injection, and then your child would not feel the pain. It would get rid of about 80% of it. We took that same thought process and go, well, you know, that works for mechanical pain as well. And I went, yeah, that's a good idea. So using it, the great part about this is not just the science, not just the fact it's research, not just because they've received grants to help with opioid reduction, but it's more also because this is really easy to use beyond everything else. We always talk about all these different gizmos. It is put it on the body where it hurts and hit a button. That's it. Now, you also have the part of it, you have a cold pack that goes with it, because cold is very good at controlling pain. But all of you out there, and you're going to go say it like, wait a minute, but when you do cold, it cuts blood flow. And you just talked about all this stuff to increase blood flow. I'm like, well, you are right. You did read all of your literature, but I also hate to break it to you. When you put a high frequency vibration at the low amplitude over a blood vessel, it also opens up the blood vessel, so it counteracts the effects of the vasoconstriction, but you still get the pain control of the cold, as well as the thing that stimulates that Pacinian corpuscle, which is now you're going to have it in your daily verbiage talking about Pacinian corpuscles. Okay, just don't bring it up too much around the family. They're going to think you're a bit of a weirdo. All right, so to do this, all I have to do is stick these two things together and put it over the foot. Here's what's fun, right? I remember before, I'll pull this up again with my camera. I'll pull this down. Here's my foot. If I had a TENS unit and it hurt here, where do I put the pad? It won't go over the tape. Well, guess what? Mechanical vibration does not care that tape is here. Okay, I can go put my little cold pack on here. And then we actually have a plantar one that's specifically for this as well. So this one's a little bit bigger. Put that on the foot. I know this is going to be super complicated. Wrap it around, okay? And then hit the button. That's it. And that mechanical vibration is going to go through the tape, but it's not going to eat the glue. So I know all of you out there have used different salves, but here's the problem with using a salve. If you put anything with oil-based on top of tape, it eats the glue in the tape. So with this, you no longer have that problem, and it's all working together nice and perfect. This one particular one for VibraCool is a knee ankle. So you're like, oh, you can only use this for your foot. Well, the one strap I have here is actually for your knee. So you could take that same thing, pop it over here, and then you get the same control. Bam, just like that. Or for the last piece is because sometimes you have tape, but you also want to put a brace on somebody. Fine. Take this thing out. There you go. And go take the unit out and go put it in a knee brace or go put it in a back brace. So I want to show you that why we like these. I'm a huge proponent of these mechanical solutions is because sometimes this is the right answer. Sometimes this is. Sometimes we have different tools and stuff to work on it, right? But then also a mechanical solution is a back brace, right? That's mechanical, okay? You could take this, stick it in there, still use your tools, still use your tape and get a huge benefit. I'm not just the president here, I'm also a client. I put this and this on a frequent basis. I just moved homes a couple months ago and these two are my best friends. So my back was killing me. The things that you experience as a clinician are the same things your patients experience. And so if you can take that and understand how you can use these mechanical approaches to manage their pain, manage their movement, and overall improve their quality of life, you are going to be an unparalleled stud. And that is a good thing because we're already separated enough in this world as it is, and it's hard enough to get individuals to come in, particularly when they're hurting. So if you can do the more you can to be able to show them mechanically when they're there physically, I can do things for you. Not only physically does it help them, but it also helps them mentally.
Amazing. Thanks for that, Keith. Honestly, I've never smiled so much during a presentation ever. Your enthusiasm is quite infectious. I'm hoping other people are feeling the same way as well. We've had a question come in from D, who is just asking what, I'm presuming, so what a percentage of stretch are you applying the dynamic tape with?
Perfect. It's great. And it's a great question because we get this one all the time. It's going to be about, you're going to take the slack up and I will take it off my foot here and show you on the screen. So with dynamic tape, because you're already putting it in a shortened position, so I'm already putting the body part really short. So you saw my foot, how I kind of clawed it up because that's the shortened position of the foot. And so when it stretches out, then the tape is actually creating the motion. So if I were to put this on the body, this is what throws people off, is I'd have an anchor, 4 fingers on this side. There you go, 4-finger anchor. 4-finger anchor on that side. And then when I put it on the body, remember it's a shortened position. Here's how much I'm going to stretch it. Ready? 1, 2, 3. Well, we got to get the right side so it looks cooler. Remember, tattoos look cooler. Okay. And that's it. And people ask, well, why do you only put that much stretch? It's because of this. As the body part moves, it's going to stretch more. If you started with 60% stretch, you would go to 100 plus and you would rip their skin off. If you start at 10 to 20%, it will get into the ideal, which is somewhere around 50 or 60% stretch when they get through the whole motion. And then the skin can tolerate that amount of anchors and recoil, and it gives you the most therapeutic effect. So I would say, again, you put the tape on, you take up the slack, go 10, 20% more, and then lay it down with those big anchors.
Perfect. Great. So what I'm going to do is I'm just going to share my screen back. so we can get the questions and answers underway. So just as a reminder to people, your Q&A, it can be found at the bottom of the screen. Please don't be shy of asking a question. Any question is a good question. Don't worry about it. You know, it's such a cliche, but if you're thinking of it, the other 30, 40 people that are on here will probably be thinking something similar. To be honest, I actually want to address something. I think with any kind of tech, gizmo, you know, kind of any kind of new product, I always look at three things: the clinical evidence, the research evidence, what's in the black and white, my clinical experience, so what do I experience in clinic, and then my patient feedback. So can I break those down? Like for, in terms of the products that you just shown us and the things that you do, what is the research and the evidence for the clinical efficacy if it's used?
So let's start with instrument assisted. So they have done clinical research that has shown changes in alignment of tendon tissue. So showing the actual change over the course of time, first treated versus untreated. How it shows by stimulating those areas, it draws the correct cells in to actually build up the tissue as you have to load it, because if you don't load the tissue, it doesn't work. You have to actually still do that part. But they've also shown it as far as for changes in the tension of soft tissue. They've also looked at it from the actual breaking up of cross, fascial alignment. They've had plenty of research that's been able to demonstrate those changes. Things along the sides of saying, well, it's going to completely reduce pain or things like that. Not so much necessarily for instrument assisted, but because you're putting your hands on somebody. Just remember, you have mechanical transduction going through. So whether it's your hands or the tools, you're going to have that effect. For dynamic tape, there's been a tremendous amount that has supported it. And that is from either from double-blind studies to individual case studies to showing the actual how much force comes out of the body. They've had research where they've shown it with volleyball players with ACLs, and that's been able to demonstrate their improvement in valgus control. Years ago, I even did a test on myself, and I used a product called Dorsibee, which is a movement technology. And I put myself through it with and without tape, and I did the thing 4 times, and I didn't walk well for 2 days. But in the end, you could see a significant difference, not even a tiny, but a significant difference when we did a hip rotation taping, because what that did is I took my knee, which was in too much of a valgus moment, and I rotated it out. Just so much to even prove the point, I did this at the University of Children's Hospital near Temple University in Philadelphia. And we did this particular taping on someone to show that we could change the valgus moment at the hip and knee. Just to prove the point, I took the good side and I made it bad. So I took what was good, what was bad, and I made it good. And just to show you, because it's a tool, right? It's a tool. Mechanically, if I push them too far, I made them in pain. And that individual was not happy with me when he took about 5 steps because his hip and his knee was killing him. But it was just to show, even on the graphs, you could see the tremendous change in movement patterns. So lots of research for dynamic tape. And then finally, when we go to the next one, we were talking about the combination of high frequency vibration and low amplitude for pain control for needle sticks. There is so much, I would have to take the next 2 hours just to explain how much research is there for pain control and for changing the way that people move, and as well as like post-surgical. Recent study was done looking at ACLs, and they actually found they were able to reduce the opioid use by about 30-35%. Another one has shown that from a pain control perspective, this type of technology is 2 to as much as 5 times more effective than a TENS unit. And the whole reason why is because a TENS unit will only hit 1, maybe 2 mechanoreceptors at any given time. A VibraCool hits all 4 at all times, which means you get the most effective pain control, and then you can use it in conjunction with your other stuff. So I support these things because they're hugely research backed. That also from a clinician standpoint, they are easy for me to use. They're easy for me to explain. They don't cause me more work. They actually cause me less work. Like that, I take the load off of me. I'm very selfish here. I have to go treat 1,000 more of you, right? I can't be wearing myself out. And the last of which is from a patient feedback, because you're able to do all of those things, you're able to get instant feedback. If you watch somebody with dynamic tape and you put it on their foot, they will change the way they walk instantly. It's because it's mechanics. If you do soft tissue work over them, they're going to have a change in the way that they move and stretch because the nerves are now gliding much better than they did before. And because they're gliding better, they have better movement patterns. And then finally, with something like a pain control for VibraCool, it's just so easy. You strap it on and you hit a button and say, leave it on there for 10 minutes and turn it off. Otherwise, everything else is like, well, if you use this sort of salve, you can't use this, and that'll eat the tape up. And then this other one that may cause a little bit too much burning. And with this one, you buy it once and you're done. You got to change batteries. I mean, what's the cost of batteries? The thing lasts for like 20 hours of use time, and then you have to change out a few AAA batteries. I mean, that's nothing. So they're also somewhat cost effective. So you're not asking to go out and get a ton of things. You're bringing mechanical solutions to them. So that's why I like these three, is because they meet the criteria of we have to have research behind it. We have to have our own clinical experience. The patient experience is exceptionally important. And then you also find that it's going to be replicatable among different clinicians.
Perfect. I think comprehensive answer there. Sold. So Michelle Dowd, thanks for your question. She's asked, how long would you use the IASTM tool for roughly to achieve the effect that you want?
Yeah. So I generally found that over each area, you can do it for 30 seconds to a minute, and you're going to get the effect that you're looking for. Others have said like, oh, well, if you get good results after a minute, then if you sat there and did that for 10 minutes, you get a better results. It's like, well, not quite. Because the goal, remember, is to break up those abnormal soft tissue adhesions and then move into the next part of your treatment. At some point, you're just beating tissue to death. So we want to have a little bit of erythema. We want to have a little bit of that blood flow increase, absolutely. But you can achieve that in less than a minute. And a whole treatment, even if I did the foot, I'm done from hip down to toe, and I'm probably done in 5-8 minutes tops.
Okay. So literally 5 to 8 minutes, that onto the whole area?
Whole area, that would get down that whole leg into the foot. Gives you also a chance to talk. I use that time to say, how are things feeling? You just incorporate the two together because the person's just sitting there. So that way you maximize the use of your time.
Right. And I mean, obviously you're looking at the erythema as well. I mean, obviously I'm an IASTM practitioner as well. So I just kind of want to point out that we see quite a lot of people that use tools that go a little bit past the pink and the red stage.
Yep.
What is your kind of message to people who use IASTM, interested in using IASTM, or even patients out there that are seeing people having that scraping gua sha type thing done? What's your kind of thoughts with that?
So my recommendation is you always start out a little bit lighter just so you can see what their response is. If they're very fair skinned, they're more likely to have a little bit more of a reddening response. We don't want to see those little dots showing up in the skin. That means you're breaking the capillaries and you've gone probably a little bit too far. There is a bit of a difference between sort of Western and Eastern thought, and part of it from an Eastern thought is if you cause a significant amount of tissue damage, that it draws the healing elements to the area. And there is backing to that. It's just that you want to try to find how far can you push without causing someone, because that causes a lot of pain as well. And it looks not good. And so the optics, the visualness of things also have to be taken into effect. Because if your patient knew like, oh, if I just beat you up a ton right this second, they'll feel right as rain, that's one thing. But you're also a physiotherapist, which means you're already beating them up with other stuff. I don't think you need to add one more thing to it.
Cool. Just in terms of IASTM, I get this a lot. I'm sure you probably get this a lot. But why would you choose instrument-assisted soft tissue mobilization over your hands? Something that we, as therapists, we train years to use. Why a metal plastic tool instead of that?
So when I look at tool, has nice beveled edges, so it allows me to grip this without having to squeeze it. So it also is very heavy. So because it's heavy, I don't have to push down hard. This is never going to wear out. That IP joint is, that thumb joint is. And so as much as I can replace a lot of the soft tissue work with this, means I get to save this.
Right.
And all of you clinicians out there, I'm preaching to the choir. How many of you are sitting here right now and you're just seeing this on my hand? You're like, man, I bet that would feel good on my hand. And yes, it does feel good on my hand. But it's because the joints wear out, and I would rather, it's just sort of like, I think like a total knee replacement, how many cycles it has to be able to take, 6 times your body weight. So let's take that pressure. It's the stuff they put on spaceships. That's because that's how much force is exerted, and that's how much it takes over time. Why don't we take the pressure off of your body parts as much as we can? Because no matter what, you're going to have to use them. So when I started using these, it took away 50 to as much as 70% of my hand workload, and I felt a tremendous amount better. And I would say that don't just use something like this for your patient. Use it for yourself, because you have to last.
So I want to ask a question, because I'm very much a mechanotransduction, I love it, because when you look at the cells that are responsible for regenerating tissue, fibroblast, tenocyte, chondrocyte, osteoblast, endothelial cell inside the blood cell, they're all mechanically responsive. So, I want to I always question and look at the place for electrotherapy and how, so from your perspective, how does electrotherapies, mechanotherapies, do they work together? Do they work in tandem? Do they work, what are your sort of those?
So what I would start with is when you look at things like mechanical transductions, just putting force into the body and how it reacts. So lazy grapes don't make good wine. All right. So tissues that aren't stressed don't get stronger. So if you take that same concept, let's look at it from an electro therapy standpoint. You can use that in conjunction to help muscles be stimulated, which is great because oftentimes they're not working as well. Because all you're trying to do is you're trying to get that particular muscle to exert its somewhat submaximal, but even to other times maximal force. So it gets stressed and then it grows, it changes. But if we don't stress the tissue, you can't do that. And that is the biggest challenge with pain. Pain shuts down our muscles, particularly when it's chronic. In acute stages, it can sometimes ramp us up a little bit. But in the chronic, like back pain, all those stuff, the wrong muscles are firing, the good muscles are turned down. And by using that interface, you can make a change. And so why I like this VibraCool is because it allowed that same vibration has a similar effect to stimulate the muscle, because you're doing things to wake it up, and you're also controlling pain at the same time. It's just easier to use. So I'm a fan of anything that's going to get the body to be able to maximize its capacity at that moment, because they're already weakened. And if they can only go from here to here, that's as far as you can get. But if they stay right there, they will keep going that way. So, or if you stress too much, they go that way. We have to find that happy balance. And that's why we're skilled individuals, because people come to us because we know that balance. And if we have the right tools with us, that we can gauge them so they're always stair-stepping upwards as far as function, reduction in pain, and finally the actual tissues get stronger, which we know is going to take 10 to 14 weeks before we have any real systemic changes. So you better be sticking with them, because otherwise it's just you are sort of controlled by physiology. We're just custodians of physiology. That's it. We can only do so much.
I mean, on the VibraCool thing, I mean, that's generally that's new to me. I mean, I'm a massive fan of vibration therapy. We use shockwave, which is high mechanical energy.
Yep.
Obviously, Lymph Touch, one of the other products, uses high mechanical vibration. Double barrel question, 2 questions here. So when you send a patient home with one of these, how long and how often can they use it for? And how how long? And sorry, it's the same question twice. I've just misread that.
Yeah, so you can use it multiple times a day. You could, and I recommend around 10 minutes at a time. And it's because you found that the most therapeutic is somewhere between 3 and 7. So 10 is a nice even number that people get, and it means they're most likely to be able to hit that threshold. You could use it multiple times a day. You could use it 3-4 times a day. Most of the time that you get benefits are about 2 to 4 hours. So you'll get continued pain control for 2 to 4 hours. Just note that eventually, like anything is mechanical, your body does return to a steady state. That's why you have to make sure you're using it for pain control, but you're doing your exercises, controlling the load, using the soft tissue stuff, because then eventually the VibraCool part goes away because you don't need it. If you've been also familiarized with vibration, like large things that shake you, well, that is more of a low frequency, high amplitude. That's like pounding into your body. That is not what your pain receptors respond to. So for those who are familiar with it, yes, it is vibration. but it is apples and hand grenades. It is two completely, they both might be round, but they have a different effect, okay? And knowing its purpose is really important. Just don't mix the two together. Like, oh, well, if that works, I'll have people put my elbow on there for pain control and I'll stick it on there. No, that will just crush some joints. That stuff, that'll crush it.
And I just want to come back to the taping as well, because obviously there's a few things going on. You've shown how they work really nicely together. VibraCool, patients can do that quite easily themselves. There will be people and patients out there, and I'm sure there's plenty of clinicians on this call that have patients probably buy the tape themselves, whether it's K-tape or dynamic tape, but specifically the dynamic tape. Do you ever advise or teach a patient how to put it on themselves correctly, or is it just better for the clinician to put it on?
So initially, yes, once they have a positive response to us, then I will show them. I'll first treat it just as you're coming in here and I'm doing this amazing thing, as I like to call it. I tell them, I'm like, here's the deal. Today, I'm going to put magic tape on you. Okay. And you're going to feel better, mostly just to set the psychological tone, and then send them out. And then you're going to see if it mechanically changes the way that they move. And then you'll know within 2 weeks if this is the right answer or not. And why that is picked is because if you can unload the tissues, you're going to have a neurophysiologic and mechanical change within a couple of weeks. You'll instantly have it when they move. That's fine. But that means you're able to reduce the load enough that the body starts working better. If this isn't working, then you can't take enough load off of the body. And if you can't take enough load off the body, that means you're going to need something far more aggressive. And that's, I would use it sometimes as a screening tool for surgery, to be honest. I would use that as going, if I can't unload it enough, then that may be something that has to be considered in conjunction with everything else. But if I know I took the load out, I worked the tissues, I changed the way the nerves stretch, I educated you on pain, I educated you on how your body moves. I've now done everything that I can do. If you respond positively, then yes, you send people home and you show them how to do this. I do warn always when it's done among spouses, they tend to, and it's just take it for what it's worth, everybody. But generally what happens is the men say that the women put it on too tight and put too much force. And it's the opposite way, the other way through. It's like my husband won't put it on there hard enough because he's worried about hurting me. I've had a few spouse fights over the years because of putting on this tape, because it's not just simply sticking it on there. You have to have a thought process. So if you ever have a patient who this needs to be put on, but somebody else has to put it on them, do not rely on the telephone game for them to communicate how to do this to their spouse. It goes bad every time. You bring them in and you show them, and then you have them in clinic do it on the patient, and that way you can see it work. That is the only way I'd ever recommend this, because this has a little bit of thought. But if you go to the website, you can sign up and you'll be able to get all access to all the videos, so for free.
Awesome. I mean, that's great from that perspective. I mean, with the I just want to talk, you talked about a little bit before about when you're treating plantar fascia is to look at calf, look at hamstrings, how important, whether it's shoulder, hamstring, whatever, how important is it for you to actually look at the full chain, and does it take long or is it relatively quick?
This is a great question. So part of your evaluation techniques, you're probably already doing some sort of movement screen, right? So we know the hip bone's connected to the backbone. We've all done the song, but let's make it practical. So if we have something even with neck pain, I'm going all the way down to the hand. Because for instance, if you have something as simple as carpal tunnel is a mechanical issue. It's a mechanical pinching at some point. Is it here? Is it here? Is it here? Or is it here? I don't know which one it is. So it would take me less time to just then evaluate, do nerve glides, and if they say they have pain, cool, why don't I just go down the whole thing? It doesn't take me more than an extra minute than if you're going, you know what, it's absolutely right here in the scaleys. Are you sure? Did you check everything else? And that's a way of also keeping you honest as a clinician, that if you have a plantar fascia issue, that it's forcing you to go feel everything else. I can firmly tell you over and over how many times it's been at the distal hamstring is where there has actually been the spot where it's been grabbing. I could also show you as many times anything, someone's having a foot problem, but it's coming along their Achilles aponeurosis, where it has absolutely nothing to do with the foot. It has to do more with how the hip was actually lining up with the back. So I would go in there and sometimes there's a foot problem, but I'm working on their back because I can see they're standing there and they're sideways. Well, I could fix that foot all day long, but unless I get them back upright, what's it going to matter? We're going to be facing the same issue over and over and over. So that's why you never do anything just in conjunction. You just, in isolation, it's important to treat it all.
I suppose that obviously in isolation, if that's their pain there, if we can help resolve their pain, their local pain, and then that's when you start to, as a therapist, you're starting to go, right, is the problem specifically there? Is it further up the chain? And I suppose I'm quite similar. I'll look at the local area and go, right, I want to solve the pain first, always with the thought of what's happening further up or further down, whichever way it is. I want to ask one last question because I'm just cautious of time here. I just want to know real quick, what is your favorite injury or area of the body to treat with these methods and why?
All right. So for me, it's patellofemoral syndrome. And here's why. All of you out there have treated patellofemoral syndrome. And it's a garbage diagnosis with a lot of chronic pain, and it's pain in the rear. Years ago, I even wrote a course on it just because I was almost challenging myself to try to figure out how to do this better. And it's because in my practice, I had a lot of teenage girl knee pain. Okay, so that's what it is. And now I have 6 and 9-year-old daughters, so one day it's going to come back to me. I already know it. But it's because patellofemoral is something that we keep trying to say, well, let's move a kneecap over and we'll fix all that. But it's the conjunction of lots of things. Your genetics are off, your tissues are off, your alignment is off, you have a weakness in certain areas, too strong in others, too tight here, too loose there. And why this system, I first used it with this type of chronic pain with kids with Osgood-Schlatter, so that chronic knee pain, and then also plantar fasciitis, because I just saw it with foot pain and Achilles issues, but particularly patellofemoral. It's just that you can use the tools and get into the little gutters of all the spots where there could be soft tissue issues. You can still do all your dynamic stretching, which we know that if it's too tight, it's going to be able to loosen up some of the nerve endings. The dynamic tape specifically is going to unload the quad muscle, which isn't working really well, to maybe give it a shot to get kicked back up. And then you have chronic pain all the time. And when you have chronic pain, you change the way you move, you cause fluid to increase in the area. And it's just this big giant circle, like a merry-go-round, and we just got to stop it. We've got to turn it back the other way. And that takes time. But when you put all three together, it is phenomenal to be able to deal with something that is really difficult when someone says, I hurt today. Why do you? I don't know. It just hurts. And it's so frustrating. At least have an answer for it and do something about it.
Brilliant. Well, look, we're going to wrap this up now. So thank you, everybody, for joining. If anybody is interested in learning more about dynamic tape and how to apply it, Keith did mention this. If you visit dynamictape.com/intro videos, there is a free educational videos there, so you can see how to apply dynamic tape in your clinical practice. I just want to say a huge thank you to Physio Supplies for supporting us with this webinar again. You can find dynamic tape on their products list available. For joining this as well, if you go to Physio Supplies, you can get 10% off on your next order with them with using the code PhysiQuip10. It's a limited time offer only until the 31st of October. Just get in touch with the guys, quote PhysiQuip10, and they will be able to honor that for you. Also from Physio Supplies, just to remind you, these guys do offer a completely free spend analysis on your consumable outgoings. Highly recommend looking into this. They state that they can save you anywhere up to around about 40 to 45% on your consumable spend. So obviously, considering the times that we're in at the moment, everybody's watching the pennies. So if we can save a few pounds here and there, it's certainly worth looking at it. Like I say, totally free. If you are interested, we're going to send out an email following this with the recording to this webinar, like I mentioned before, so you can look back. Also with a Survey Monkey, so any feedback, please send it back. And if you are interested in that free cost analysis on your consumable spend, please register your interest and we'll put you in touch with the team at Physio Supplies. Otherwise, Keith, thank you so much for your time, enthusiasm, and sharing all your knowledge. And thank you, everybody, for joining us this evening.
I appreciate it.
Thanks, Keith. Take care, everybody. Have a good evening.
Bye.
Bye-bye.